Hey Victoria, can you grab me sharing screen access, please? I can't. I forgot how to.
Yeah, sorry. Go ahead, Thomas.
No worries, no worries. I forgot how to use the host key. Let me get. Good afternoon, everybody. We'll wait 1 or 2 more minutes, and then we'll get going. Okay, good afternoon, everybody. Welcome to another Thursday community work group meeting for HiPAM. Glad to see everybody or have you guys join us today. Before we get started, I wanted to just, I think everybody here is familiar, but I wanted to introduce Rukia. I apologize if I mispronounced your name, but I'll let her introduce herself, but she is on board the HiPAM team. She is gonna be assisting with the slide compilation, Komi-Sutram literature, and then eventually some of the video editing. So she's going to be helping out HiPAM for a while. So definitely want to welcome her. And I'll let her introduce herself and then we'll get going.
Thank you. So yeah, I'm Rukia Walker. A little bit about me. I'm from Kauai. I'm in my last semester at Manoa. I'm getting my bachelor's in mathematics, and I'm really excited to be joining you guys. So thanks for having me.
Welcome, welcome. Let me get my bearings. Okay, perfect. Okay, so good afternoon, everybody. Let's go through the weekly COVID summary. From last week, our 70 case average alters a little bit because CDC updates their numbers pretty regularly. But last week was 44,984 for our moving 7-day case average. You can see a pretty sizable increase from last week to today for the national average. We're above 50,000 again. And if you remember historically, we were around this mark close to the end of June, early July, when we were debating reopening. So just it's like the twilight zone. Halloween's coming up, but I feel like these numbers remind me of a few months ago. But it's just noting that we were increasing pretty significantly from a national trend. These are our numbers from last week. 91.1 our 70 case average, 6.7 hospitalizations, 3.9 fatalities. It's trending down slightly for the state, which is good. I think that was aided by pretty low numbers. I want to say Sunday, Monday, Tuesday. Hospitalizations have increased slightly and fatalities have decreased slightly. But what's going to be interesting to note is whether or not we see a lag, or if there's going to be a lag once again. Going back to, we're seeing increase in the national average. And then if that's going to translate, especially with the Trans-Pacific travel opening today, if we're going to eventually see that moving back to Hawaii. For our local snapshot, our 7-day new case average decreased from 110 last week to 101, so that's good. Once again, we're still trending down as we reopen. Oahu County is still under their tier 1, so they're most restrictive. Our 7-day new death average increased from 3 to 10. It may seem like a very big jump. However, we have to remember that fatalities is probably the most variable when it comes to the metrics that we look at. And it's especially because of how drastic age and comorbidities play a role. For our 7-day new hospitalizations, we doubled from 5 to 10. Once again, there's going to be some variability as well. A lot of times, I'm suspecting a lot of it's due to the cases on the Big Island, due at the VA facility and some of our elderly facilities. Good news is current ICU hospitalizations due to COVID continue to decrease for the 3rd or 4th straight week from 35 to 27. And there is a slight decrease in the overall ICU usage, but it's still holding pretty steady. So that's one thing, another thing to keep in mind as we look forward to the next month or so. Percent positivity, the 7-day average has increased. We were actually below 3% for the past, I want to say 2 to 3 weeks, and then today or yesterday, it's now above 3.5%, I believe, for the state. And that's another thing to keep a look at. If you look at the day-to-day testing volumes, it seems like we're slowly decreasing the overall testing volumes. And then we can see with the testing turnaround, we're really doing well in terms of the proportion of our tests that are being sent and returned within 24 hours, which is great. But our overall testing volume is slightly lower. Once again, this is lagged a week, so this is for last week that we're looking at. And it will be interesting to see whether or not this decreasing trend of testing volume will stay the same, or if it will increase as, once again, we open up today and we look forward to the next 1 to 3 weeks. I mentioned the national increasing trend. Texas is going down, but once again, these weekly fluctuations, it's still good to look at the past month or so to look at overall trends. Arizona continues to increase up. California, a slight decrease, but you can see that it's not, we're a lot of like Texas and California, they're pretty much plateaued right now, similar to Hawaii, where you have minor variations up and down, but it's not a continuing downward trend week by week. So that's something we're going to keep in mind. One other thing that we're going to try to add in for next week is just looking at the total percentages, our total proportion of states relative to the 50 states that are having that are having increasing cases. I think last week we were about 50% of all states had increasing case counts. At this point today, I think it's over 30 states, the news. So that's, once again, something to keep in mind. And what's also concerning is that we're seeing spreads in very rural communities that weren't hit yet. So now it's really permeating. And with travel increasing in the holiday season, flights opening back up, it'll be very interesting to see, once again, how this spreads to Hawaii. So moving on to our COVID science highlights. The first article, I'm not going to spend too much time talking about it because we're going to be very fortunate in a couple of weeks to have Marguerite do a little more of a deeper dive, but I wanted to kind of prime everybody to read this post, this article that she shared with us. And I'm paraphrasing the title, but can genetics help with better understanding of COVID transmission? So once again, utilizing yet another really sensitive tool to really help us figure out the transmission patterns for COVID. And Marguerite can confirm, but I'm pretty sure I checked with her. So we can utilize the same samples that we use from the nasal and the nasopharyngeal swabs for the genetic testing. So once again, we're not duplicating resources. We can just, if we have a good system set up, we can, get more and more data and get a little more sensitive to genetics of that. So that's probably all I'm going to speak to and kind of dangle that in front of everybody, and to come back in a couple of weeks to listen to Marguerite give that great talk. The other article that I wanted to highlight, and I think is a really great read, especially in the times that we are in with social media and how people get their news sources, both political, non-political, science, non-science. So this was, so here's that genetic article that Marguerite shared. And then here's this article by CIDRAP. This is a really good source if you want to look for both a deep dive and a regular, just a general sense of COVID. CIDRAP is a really good source, but basically some of the main points confirms what we suspect. 70% of the people surveyed, and this was all adults on Facebook, 70% use mainstream media. About 50% of the demographics were females. I found this interesting. On average, the respondents use about 6 sources of information. So that's good. They didn't just rely on CNN or New York Times. They did go to quite a few sources. And then what's interesting is there, possible connection between news source and different COVID origin theory. And what I mean by that is, if you're a little more, if they went to news sources that tended to be a little more right-leaning, they pushed a certain narrative versus central and left-leaning pushed the more scientific narrative. So once again, nothing groundbreaking, but this is, the strengths of this is it helps us increase the understanding of a really important issue of the communication of COVID. The science is important, but also the social science as we as scientists and concerned public try to communicate better and get people on the same page. We have to understand where people are getting their information and the demographics. And so the other results are directly applicable to scientists and communication experts. A strength, one thing that was really good to see was that the majority of those who responded said that their main source of trusted information was government websites. Now, I know CDC and NIH have had their issues, but that was really affirming for me to see that still a large part of them put a lot of trust in the CDC. Limitations, selection bias, adults on Facebook. And unfortunately, this was conducted in March and April. And in the age of COVID, a week may seem like an eternity. So you can imagine 5 or 6 months now, that's eons ago in terms of how people perceive everything regarding COVID and the economics and everything else. So that's some of the limitations with this particular article. So I'm just gonna kind of go through this because I think this is our deep dive is going to be very interesting, and I want to listen to everybody's thoughts. But are there any burning thoughts or questions regarding these 2 articles or any of the data trends that we saw for the data summary? Everybody's waiting for Marguerite's presentation in a couple of weeks. Got it. I love it. Okay, so the deeper dive topic for this week is everything flu, in terms of what is flu going to do to Hawaii, how is it going to interact with COVID, what is going to do nationally, internationally. So I put a few articles for everybody to read that I thought really did a good job summarizing a lot of these issues from multiple perspectives. Here's one. Here's an editorial from Science. Here's another one from JAMA, and then another one from CIDRAP. So basically, there's differing opinions because really there's huge uncertainty amongst the experts in terms of what's going to happen. I think they can all agree that the one thing they agree on is we don't know exactly what's going to happen during flu season and how that's going to impact COVID. So you have this perfect storm scenario where, because at least in the Northern Hemisphere, it's getting colder, you have greater decreased mobility. People are staying inside longer with their families, have social gatherings because of all of the holidays coming up. Factoring that in with COVID fatigue, so potentially decrease adherence of wearing masks, physical distancing, hand hygiene, probably increased consumption of alcohol. All of those factors will probably, in a perfect scenario, will increase your risk of transmission of not just COVID, but also seasonal influenza. And we don't know what the vaccination rates are going to be like in Hawaii or nationally yet. It's still too soon to have a really good sense. So that's the worst case scenario in terms of all of this happens, and then you just have people with the flu and with COVID left, right, and center. And then you just see this, hopefully we don't see this, but with this perfect storm, we could expect an exponential rise again I know Monique and Itzvan, you know, it's either exponential increase or exponential decrease, and with that, that will definitely see an exponential increase. Hopefully, we'll see some sort of an alternate scenario with increased educational campaigns. Due to COVID the past 3 months, we're hoping that the message has hit home where we'll have higher than normal adherence of physical distancing, mask wearing, and hand washing than we've seen in the past due to just regular flu seasons. And hopefully that will result in lower COVID and flu transmission. Some interesting notes when I was reading, perusing the scientific articles, in the Southern Hemisphere, Australia, Brazil, South Africa, Chile, some of these major nations, they actually reported little to none, very little to zero prevalence of the flu for this season. Now, you know, once again, there's probably a lot of nuance to that, but I found it interesting that Australia is a different continent, and then you have South America, and then you have Africa, and countries in all through the major continents in the Southern Hemisphere reporting lower than average flu rates. So once again, maybe that's a positive sign to come for the United States in the Northern Hemisphere, but it's still too early to tell, but that's a good sign. So what does it mean for Hawaii? 2017 to 2018 ILI age distribution. We know that the flu is slightly different in terms of the impacts for the age categories. It impacts more proportionately at a greater proportion of those younger, age 5 to 24, than COVID. COVID's the opposite. It impacts those 65 and older. So once again, that's a major difference when we're thinking about the impact and how we can compare flu impact to COVID impact. Hopefully, with increased distance learning, mask wearing, less social gatherings, we'll see a decrease. Right now, because a lot of the schools are virtual, hopefully, I think looking at the current trends, the green is actually right up until a couple weeks ago for the MMR influenza week, the MMWR week. We're actually much lower than average than our baseline for where we are calendar year compared to last year for influenza-like illness. And once again, this is kind of outside my realm, but if I had to guess from an epi perspective, part of it could be due to just, you know, less social gathering, physical social gatherings, but also a lot of the schools being virtual. So that's something to keep in mind as the discussion shifts towards reopening schools. So once again, we don't know. We'll probably be somewhere in between. The other thing to think about in terms of influenza reporting is we suspect some of those numbers may be underreported because of decreases in visits to PCPs, and hopefully Dr. Wu, Dr. Behrman can speak more to that from the clinician side. We do see similarities in symptoms between flu and COVID. Once again, we have great clinicians on this call. And what that means for clinicians, I'm guessing, is they'll probably have to test for both COVID and flu. And there are some supply chain issues and test capacity issues if they're using multiple swabs, unless you're using the same. If you can use the same swab and same materials for that, and hopefully, Brian, you can speak to that in a little bit. And then I just want to end with this last slide in terms of additional Hawaii-specific questions. Will we see an influx of flu? I think we saw a really low prevalence of flu earlier this year because just travel shut down. And looking at Hawaii typical trends for flu, we get a lot of our flu from visitors, both returning residents and tourists. And because travel was so much lower than normal, we didn't really see much of a flu earlier this year. And Hawaii typically has a year-round seasonal flu just because we get visitors from the northern and southern hemisphere as they escape their winters, and they come to a warm place like Hawaii all the time. So we don't really get a break from flu that other places typically do. Hopefully, you know, with this being a data and a science-driven group, the goal is to eventually access data from DOH's renewed immunization registry just to see, look at flu vaccination trends again, and hopefully eventually we can get access to COVID vaccination numbers as well. And then for us, keeping in mind the next month or two, hopefully avoiding a perfect storm scenario, but keeping an eye on all the metrics to see if these creep up, if we're reaching a point where we do potentially see a perfect storm. And then I'm going to close it out with next week's deep dive. I believe Marguerite and Tom will be talking about schools reopening and that scenario. So definitely something to look forward to. And with that, I will open it up to everybody and let's just have a great discussion.
Yeah, I want to clarify about the immunization registry. Last week, I thought that it's up and running, but then this week, yesterday, I got some clarifications that actually it's still in the testing phase, and the contract is not finalized yet between the Department of Health and the vendor. And so, you know, I guess I jumped the gun a little bit when I said there wasn't enough technical support, but of course, because there's no contract, so the vendor is not going to provide the support. And hopefully within the next few weeks that the contract between the Department of Health and the vendor DXC is finalized, and then we will be able to get more. Previously, I think that's the same vendor as before, and I think there is a portal that is accessible as well as electronic query available for the immunization registry. So HHI is looking forward to that and see if how we can help with that.
Wait, Thomas, you're on mute.
Apologies. Go ahead, Brian.
Thanks so much. That my few brain cells could not handle such an explosion of information that you did so great in providing in such a high yield fashion. But yeah, we typically, when I last recently discussed with our labs, we do have a little bit of seasonal variation in flu in Hawaii. There is a higher prevalence, usually around January through March-ish. And then interestingly, we have a little peak in the late summer as well. And again, could it be because of the Southern Hemisphere difference and traveling? Who knows? But it was really fascinating. You know, like you pointed out in Australia, I think in August of 2019, they had like 69,000 lab confirmed flu. In August of 2020, it was like 100 something. So it's a pretty profound difference. But, you know, like you mentioned, and as we all know, the kind of the devil's in the details behind data. You know, with the age difference in flu versus COVID, well, we do know that children's symptom severity in COVID is less, so they just may not be testing positive. And we know that when kids get flu, it's, you know, very, very uncomfortable, so they tend to get tested more. So again, is there that true age difference prevalence, or is it just kind of a sampling thing? But I think a lot of folks do not suspect that this is going to be probably maybe a very low flu season, like in the Southern Hemispheres. But the issue with flu vaccination public messaging, because I'm kind of involved with some of that as well. I think the big thing is, because like you said, you can't differentiate many viral illnesses from COVID. If you do get the flu, you may be subjected to COVID-like restrictions. So I think from a public messaging standpoint, why should you as an individual get tested? That's one positive reason why. And from a healthcare system, the reason why is, yeah, if you do get, you know, double whammy, or if you just get flu by itself, because we know it leads to many hospitalizations in high-risk populations, just another reason to not stress our healthcare system. But yeah, I don't know if it will be a perfect storm of flu and COVID. I think in the mainland particularly, maybe more for COVID transmission. But here in Hawaii, you know, in the winter, I mean, we have holiday seasons, and you hear that public messaging already with Thanksgiving coming up, with Christmas coming up. Don't have your big household, you know, celebrations because of the transmission risk for that. So I probably made no sense there and am incoherent as usual, but that's my half percent.
That was super helpful. No, that was super helpful, Brian. And once again, it really helps to have a clinician's point of view, because you guys you're in the front lines and you get to see the patients and experience a lot of that. So I hope that there's no perfect storm, but it would be irresponsible not to at least bring it up and discuss it and try to avoid it. And that's part of our purpose, is to provide scientific guidance and to concern public to at least, and once again, the worst case is we just kind of sound a slight false alarm in terms of, hey, this is what could happen. It shouldn't, but in a perfect storm, then everybody's behavior shifts again to avoid that perfect storm. So once again, that's a goal. But thank you for that insight.
I forgot one other thing in terms of the testing. So there's going to be, so the local labs here, the machines that they use, some of them, there's going to be hopefully FDA's approval in November, where the same sample will be able to test for both COVID and for influenza. So it's going to be a single sample for it. It's just the cartridge will be different. Yeah, just, I think you inquired about.
No, that's perfect. I mean, then that's one less negative for a potential negative impact for flu/COVID. So that's good. That's super good news. Any other comments, questions, Dr. Behrman?
Oops. Sure. I think actually Dr. Wu covered just about everything I would have said. I guess from the, because I'm not in the clinical world right now, I'm really in the public health world. You know, we do know that flu and COVID-19 are both respiratorily transmitted viruses. And so to the extent that we as a community are taking all of these measures to try to prevent transmission of COVID, we will inevitably also reduce transmission of flu. So I think that that the perfect storm scenario is likely only if we utterly fail as a community in terms of preventive measures. And I hope that we won't, because that would also be a failure of public health. That said, I don't think that's a reason not to have a full court press in terms of flu vaccination, because again, as Dr. Wu said, you could, very unfortunately be infected with both, or be infected with one and then the other and be more susceptible to more severe disease, especially if you're in a high risk category, because at the higher age group end and at the chronic disease end, the high risk groups are similar for both diseases. They're different for very young children, but they are similar across those adult ranges. And then also, of course, the impact on the healthcare system. Testing, potential inpatient impact, all of that is important. I think that's less compelling to people in terms of a reason to get a vaccine than the notion that it protects you, it protects other high-risk people in your household and all of that. So that's all I have to add. Thanks.
No, thank you, Dr. Marin. That was super helpful. Andrew, I think you posted a question that I definitely cannot speak to, if you want to share that with the rest of the group.
Yeah, really quickly. First of all, sorry I'm jumping on a little late.
No worries.
For have we anticipated, Thomas, if our models are incorporating an influx in testing not based off the spread of COVID, but based off of flu symptoms?
To my knowledge, I don't believe so.
Yeah.
Levi, I don't know if you want to speak to Levi or Bobby, and then Monique, I'm not sure about your specific model, but I don't think we've, at least for our HiPAM models, if we've differentiated specifically for that scenario, testing scenario.
No, we're focusing specifically on COVID. We haven't done any kind of modification for flu yet. It would be a little too complicated as it stands right now. There'd be kind of a lot of guesswork, so we're sticking to COVID at least, unless there's it becomes more evident that there's a lot of risk or a really dire need to do so. It might be too complicated to get any kind of accurate estimations.
I don't think the positive rates will. I'm just thinking, because a lot of the symptoms will be so similar, that even this, when you take a look at the side by sides, at least when you take a look at flu and the cold, there's differences in like myalgias and fever. When we take a look at flu and COVID, it's kind of hard to distinguish even for healthcare professionals, really. And so you're going to see a lot of people getting tested just to make sure they don't have COVID, but they may have the flu. And since it's flu season, I would see the symptoms in general start to increase, not due to COVID. but due to the flu. So I don't know if other people have been starting to incorporate into their models like leftovers from people, because the symptoms will increase, but they just may not have COVID. But in additionally too, Thomas, I think, I'm not too sure, because I know it was a great campaign initially. All the health plans kind of fell in line with the initial testing phases, because they believed, testing should be free for COVID and whatnot. But at this stage, I think a combo test is great because they'll knock out both at the same time. I just want to make sure that, because when I first got my test, I thought it was kind of a little sketchy, because I went to Al Moana, one of the healthcare providers swabbed me and they said, what coverage do you have? You may or may not be charged. I'm like, oh, I know I'm not going to get charged. But flu test too. And I said, because it might be treatment for it. I'm like, I declined that, because if I have the flu, I'm just going to stay home and I don't need Tamiflu. So I declined it, but most people will accept it. But health plans may not. Some of the health plans may not waive the flu shot, the flu test. So I want to make sure that we don't have people, masses, going to get tested and they inadvertently get a bill because it's a combo with the flu.
And I can share from my HMSA hat a lot of the complexities behind all of that. That may take a whole session, but I don't want to take up much time. But definitely, it is an incredibly complex thing, and just a small snippet of the complexities. Typical CPT codes for testing. There are actual manufacturer-specific tests for this, codes for the same test coming out on a regular basis, because I'm reviewing these. So it is an incredibly difficult system issue in our wonderful country.
Yeah. For anybody who wants to some light bedtime reading, just look up ICD and CPT codes, and that'll put you straight to sleep in about 1 minute flat, or faster. So, but that's really helpful. That's good perspective. Go ahead, Andrew.
For combo tests, we had some issues because with the issue with a lot of fraud being raised up during COVID times, a lot of people have a lot of medical fraud, especially with billing. If you do a combo test, but you bill 2 codes separately instead, one for flu, one for COVID, you can get double billed if you have the results, but you buy a cheaper one test. That's like piecemealing it out. And I just want to make sure that the patient's not left with the bill. Because if they go to help and someone recommends they get this, they're just going to say yes. And that's my fear, that we're going to have a large increase of people agreeing to services they don't know they're going to get charged for.
Sorry, go ahead.
The provider group that I talk with here on Kauai regularly has brought up the issue of reflex testing, where you run the flu test, and if it's negative, then you run a COVID test, but if it's positive, you stop after one. And I know that has implications for billing also, although I'm happy that I'm not in a world where I know what those implications are. But it's also interesting to think demographically, if it might, or epidemiologically, if at some point the logical way to do that would be the other way around, to test for COVID first and reflex flu, which really depends on which is more common in your area, I presume. So just food for thought.
I just wanted to say something maybe in terms of the models, just to clarify, because I've been thinking about it and it wasn't really clear. I think it would be modeling 2 different things. The model that we're using now, we're modeling the spread of the COVID. And I think this is sort of a little bit disconnected from the spread of the flu. So like co-infection is sort of rare, and that, Andrew, that's what you said, right? That means that we have basically 2 parallel models running next to each other with very little interaction in between them. But I think what you're asking is a different model that is trying to model testing procedures, right? And depending on the symptoms that you have, what type of testing you're going to have. So the model would have to be structured different, because you're trying to model something different than just the spread of one disease versus the other one, or the interaction of both. So it might be feasible. I don't know. I haven't seen anything that is actually modeling the testing itself as a priority.
Yeah, it's not an easy question. And then I mean, for everybody here who may not play in the insurance provider space, you can see how quickly we just talked about flu, and then and the safety and the sensitivity and the accuracy of the test, and all of a sudden we ended up in health insurance and this very, very, very complex world that, I mean, everybody should be aware of, because we all pay so much money to have coverage, and that's just the first step, and understanding that. And you know, what COVID has once again exposed is the inequities in access to healthcare and treatment. And once again, this is just yet another example of you know, public health and messaging and access to healthcare, and making sure everybody has the right care possible. But this is really good, because once again, there are just as important things besides the math and the science and the modeling to this response. And it's good that we approach it from a holistic perspective as well. So thank you, Andrew. Thank you, Brian. Thank you, Dr. Berman, for that. Any other questions, comments on the flu topic? I know we have about 20 minutes. And if not, we can kind of talk story a little bit. I'm not sure if anybody today's a day to celebrate / look at in terms of the first day of Trans-Pacific opening. I am curious to look at the numbers tomorrow and see if we actually did get 7,000 travelers, which is what was reported the expected volume. So we'll see, because that's about, you know, I think we were averaging like 1,500 to maybe 2,000 a day, and we more than tripled that. So, and if that continues to hold steady, if it's just today, or if we're going to see a steady increase from 7,000 upwards. So, because I think everybody here is familiar with the possibilities that travel volume starts to increase. So if there's any thoughts on that, we can definitely pivot to what's happening today and then the rest of the week.
Tom.
Yes, sir.
The Star Advertiser today had a fairly detailed article about DeWolf Miller's leading a team to supervise Dr. Green's, Lieutenant Governor Green's, what he's calling the surveillance program. And it seems like the goal is to verify that the plan that's in effect today, what's being called the one pre-flight test plan, is sufficient to reduce incoming infections to I'm going to use Dr. Green's term, manageable level. That makes my skin crawl, but because I don't like to manage sickness and death, but I'll try to avoid getting too political. But I did want to know if what the group thought, if there were the problems. And I'm an engineer as well as a lawyer, but I'm not a data scientist, and I'm certainly not a epidemiologist. But when I look at that, they're trying to draw conclusions about the population of incoming visitors, and they're, you know, what I learned about statistics said that you have to have a proper sample to do that, and in fact, a random sample. And you know, if you're going to rely on people volunteering, and you're probably going to have to get 10%, even to get 10%, which is their goal. I don't even know if the science, that's the number that the science predicts you need to reach a certain confidence level, but they've jumped on that, or at least Dr. Green has. DeWolf Miller hasn't said too much, except that he's confident he's going to feel safe once the results are in. That kind of presumes a conclusion, but whatever. It seemed to me there was problems with arriving at that. And, you know, for the group, I'll put on my attorney hat or my social observer hat. I listened to DeWolf Miller, and I had some short correspondence with him, and he's definitely a character, and he's not going to be the kind of person that Dr. Green can rein in, that's for sure. So I suspect that you know, his study and his conclusions, whatever comes out of his group is going to be valid. If he winds up walking away, I'm going to be very concerned. And I think that, you know, there's a possibility of that happening. But two things. One is, you know, I don't have to counsel people like DeWolf Miller about the dangers of wading into a morass like that and getting sucked into a position where you're doing things that you really don't want to do. Anybody that listened to Dr. Fauci has got a master class in effective public health discourse and communication and political survival. You know, he's been able to stay in the forefront of the public of the public by not getting his butt canned by the administration, and the fact that he's still there is incredible. For a lot of the people in HiPAM, especially people that haven't, you know, been through the political wars and have been kind of isolated in academia, I'm really going to counsel you to always be aware and seek guidance when issues come up where you feel, no, this isn't right. I'm being asked to do something that isn't right. Don't take that. Don't realize that once it's way too late and you've gone down to the dark side and you don't know how you got there. Because I'm so impressed with the level of integrity and the dedication to the science that the group has, but I really see that as a real danger for some people winding up in that position. So take a cue from people like DeWolf Miller, who's not going to be corralled by anybody, and is always going to let the science speak for itself, even if it's not the most coherent message in the world. His integrity is as far as I can tell, and from his reputation and his body of work, is unassailable. And when you get to be his age or my age, you want to be able to look back and say the same thing. And the way you get there is one step at a time. So I'll get off the soapbox now. But I'd appreciate any input. I'd appreciate any input on what people think about what's going to be necessary and what are the pitfalls of this scheme to try to get a statistically valid answer to the question, how many infected people are coming into Hawaii? And bear in mind that DeWolf Miller was the only epidemiologist who was on the team of 3 authors that wrote the only paper that I'm aware of that was published on the one test system that Dr. Green appears to have adopted. So I think he's got a little bit of a bias to prove that he was right the first time. But I think he even said on a radio live Facebook program that when he was asked, the question originated with me, but he was asked if they planned to do an update of that paper. And he didn't answer the question, but he said, well, everybody out there who thinks they're an epidemiologist is already answering the question, so why do I need to work? But he said, no, a lot's changed since then. There's new information, there's new data. And so I guess he's going to get a chance to answer that question himself now. But I'd be curious to hear if anybody has any thoughts on pitfalls or problems with even the concept of trying to do that. Thanks.
Thanks so much, Jim, for your insight as a former Deputy Attorney General. I think that's a perspective we normally don't get, and is definitely valuable, as we know how political this issue can be. In terms of this one test strategy, I will, Isfan, would you I know we've discussed this before, but I would love for you to share your thoughts about this with the rest of the group, and then we can, anybody else who wants to chime in can definitely do so.
Actually, so what I was saying earlier, I thought that maybe, focusing on returning residents would be one good idea in terms of a second test, because they are more likely to pass on COVID than the average tourist. But what I like to highlight as another pitfall is an article I read actually yesterday, which compared New Zealand and Iceland. And both countries actually pretty much eradicated COVID through a very, very strong public health response originally. And both being islands, they then focused their efforts in controlling travel. So there's almost no COVID in New Zealand. It's like a handful of cases and they're all due to travel. And today there's like 100 cases per day in Iceland, but only since the last few weeks or months. And the only difference is that in September, somehow 2 French tourists, 2 of them went drinking. And these 2 people sparked directly something like 120 infections, or between 50 to 100 infections. I don't remember the exact numbers. And that sparked a cluster that is still going on since September today. So again, I guess I just want to emphasize the issue of super spreading. Like if you get the average, like the number, like what fraction of tourists, like how many infectious people do we get per month out of these 7,000 is one thing. But if 2 of them go to like a spree, and this reminds me of the earlier story of the Korean guy who did the same in Seoul, again, sparking a whole like visible cluster. So, just these raw numbers, like how many people are infected, are not enough. So I think we should somehow try to concentrate the efforts into the high connectivity ends. And, like the math also plays out, like the math kind of is consistent with this kind of stories that, there are some people who will just infect a lot of others because they're super spreaders, and that's, probably a behavioral issue. So, but basically the conclusion of the article was that maybe the Iceland people were just unlucky that there was these 2 guys who happened to, like most people understand the quarantine rules, and most people actually adhere to them. But even if it happens on occasion that somebody doesn't, they might not have COVID. It's like 2 rare events. But finally, they had these 2 guys who had COVID and they didn't adhere to the quarantine. Then they went drinking, and they were especially big drinkers, and they went from bar to bar and infected all these people. And now they have 100 cases. They have more cases than in a while. And they claim most of it is traced back to these 2 guys. That's pretty amazing to me. So Iceland has 350,000 people for reference. So it's about 3 times smaller than Oahu. So 2 guys could make a difference on that island. That's what I wanted to say.
Thanks so much, Isma. I think that's a really good point, and I think the take home is we can do everything right and just random chance, right? All it takes is 2 random people to be the ones who are super spreaders, and then just you can do everything right. And the good news is, and it's fine, correct me, the good news is it didn't overwhelm their system, because once again, everybody followed it, so that even if they had this super spreader event, it wasn't, it was an outlier. It wasn't something that added to an existing increase.
Yeah, I think they probably discovered it a little bit late because they have eradicated COVID. They went back to kind of a normal life, and they focused all their effort to contain travel, and they had very strict rules. But apparently New Zealand is stricter in terms of enforcement. So I guess Iceland relied more on voluntary, like they didn't check as much, or they didn't force people as much, while in New Zealand apparently like it's very serious, for travelers. So that's the difference. But yeah, I mean, small accidents could spark into something big easily.
No, thanks for sharing. Yosh, I wanted to not pick on you, but I want to see if you had any thoughts in terms of from a mathematician's point of view, that one test scenario, if you thought about it at all, because I know it's been a while since we've caught up, but if you've thought about that question from a modeling perspective.
No.
That's okay. I mean, I know where your focus typically lies, and that's a little outside your day-to-day scope, but I was just curious if you thought about that at all.
No, honestly, not yet. I think I want to see what the numbers sort of look like and get a better, clear idea of how it's going first.
Okay. Yeah. One, Dr. Berman, do you have any thoughts?
Two things. One is that the lieutenant governor's plan to do a surveillance, which he's characterizing as an assessment of kind of the impact of travel, and saying that he'll test 10% of arrivals voluntarily is obviously not a rigorous approach to this. And I've been one of several people sort of saying in various work groups that there needs to be science behind it. And I think the danger is that whatever information comes out of there will be used to tell a story that that may or may not be supported by actual scientific information, as if it is scientifically supported. I would encourage the group to also maybe be aware of the work that's going on in Maui. Dr. Pang is working on doing a smaller, but I think somewhat more intentionally designed testing of people after they've traveled, in order to try to get a sense of how much disease is introduced from there. I'm afraid I don't have details to share with you, but it is more of an attempt to do something rigorous, relatively small, time limited, with a sample goal and a sample frame. So there may be information from there. And we're on Kauai doing essentially convenience testing of voluntarily of both returning residents and visitors. It will not be a rigorous scientific survey, but we will have those data. And then the Big Island is testing everyone who arrives at the time that they arrive. So there may be very little time difference between that and the pre-test, but they are testing everyone. So I think that regardless of what happens with the LG's study, we will get information from each county from these various approaches, and it would be really interesting to have this group play around with those numbers and see what we can learn from the totality of that.
Yeah, that's great. One question on that, Janet, and I know on this group we've discussed, I feel like ad nauseum, about access to data that we can actually play around with. Do you know, and I know you can't speak for Maui County or Hawaii County, but is there an appetite to share whatever CSV file or workable data, or is that something we can pursue as HiPAM to make inroads in?
Absolutely. I mean, the results. Well, I can't speak for Maui because they're doing a lot of I think they're doing rapid antigen testing, so I don't know how completely that will be folded into the DocD data, but I think that Dr. Kemble would be very open to sharing the data, and that's certainly something that HiPAM should pursue. And
Perfect.
I'm happy to be a conduit for that.
Awesome. That sounds great. We have about a few more minutes, and I want to be mindful of everybody's time. We went over a couple minutes last week, so I want to be considerate and hand that back. Any last minute questions or alibis or comments before we wrap it up for today? Everybody's just want to crack open a beer or pour some wine. Tom, great point. Systematic sampling can still have non-response issues. I mean, there's no perfect, unless you're doing a double-blinded placebo case control, or a cohort study. It's never gonna be a perfect study, but if we can get it as good as it can get, then that's the goal. Though I don't know about just 1 every 10 is rigorous, especially with our understanding of the returning residents as being the main drivers of community spread, not so much the tourists. So if we're doing just 1 every 10, we may not be weighting accurately the sample to accurately capture the true the higher risks populations for those transmitting it in the population. So still lots of work to be done, but with that, I want to wish you all a very happy Thursday and an Aloha Friday tomorrow, and please join us next week. And yeah, if you have friends who are interested, they can make the meeting. Our videos from today will be up on our website tomorrow, and with Rukia on board, our goal is to make it a little prettier. in the next few weeks. So stay tuned for that. But I wish you all the best this week, and we'll see you guys next week. Thank you, everybody.
Thank you. Bye.